So, whenever I am asked to talk on this topic, syndromic obesity in children, the picture of this poor boy flashes on my mind. So, anybody in the hall can recall the name of this child? Travel 20 years down the memory lane. I was in my 10th standard at that time. This was 2005. So, anybody in the hall can remember the name of this child? Lokman. Sir is always right. So, yes. So this unfortunate child was Lokman Rahim, and he presented with extreme obesity. He was 8 months old at that time, and he presented with a weight of 22 kgs to one of the most premier academic institutes in Kolkata. And I don't know how much we should trust the news media, but they say that doctors were baffled at his diagnosis. They did not know what was the problem with him. And he consumed around 5 liters of milk and 1 kg of flour per day. Come 10 years down, 10 years later, so 2015. So any students over here? Medicine or pediatric students over here? Anybody? Okay, so the rest of the hall, I presume, of course, they know. So 2015, 10 years after the presentation of Lokman. So these were like, I was doing my residentship in medicine at that time. And this chubby kid with small cute eyes, or this child with multiple fingers and some problems with vision, these would be spotters for me, and we would be thrilled because it would cater for a good academic discussion. 10 years later, 2025, do we still have anything to offer to these poor children apart from advices about diet and a bowl full of fruits? Let's see. So talking about obesity in children, exogenous obesity still accounts for the largest proportion, but there are multiple other causes of obesity in children also which we should not overlook. Of course, endocrine disorders, Cushing's syndrome, pseudo-hypoparathyroidism, to some extent hypothyroidism, untreated severe hypothyroidism, and then the genetic syndromes, which could be due to problems in the leptin-melanocortin pathway or could be due to some other problems presenting as syndromic obesity, which affects multiple other systems as well. So 5 to 10% of children with early onset obesity can have an identifiable genetic condition, which could be either due to problem in one particular gene called as the monogenic obesity syndromes in the leptin-melanocortin pathway, or it could be pleiotropic genetic obesity syndromes affecting multiple other systems as well. So when do we suspect a monogenic or pleiotropic obesity in syndrome in children? Let's look at the approach towards an obese child. So early infancy obesity, it should be a marker that it could be a defect in the leptin signaling pathway. Then after we have ruled out drug-associated weight gain, poor linear growth despite having weight gain, it is indicative of a possible endocrine disorders. If there is any history of intracranial lesions or intracranial surgery or radiation, again, it could be some problems with the hypothalamus. And then if there are either developmental delay or dysmorphic features, especially in the face or both, it could be some of the pleiotropic obesity syndromes. So we are primarily concerned today about the monogenic obesity and the pleiotropic obesity syndromes. So rapid weight gain right from the early infancy is the most important feature, which could be a pointer towards genetic obesity syndromes. Then severe obesity, BMI higher than the 97th percentile for age. Persistent hyperphagia, mostly reported from 6 months of age, in many cases later on. Then signs of hyperandrogenism or severe insulin resistance, parental consanguinity. Here, family history is mostly negative because most of the syndromes are autosomal recessive, or there are some other pointers like tall stature, decreased pigmentation of hair and all. So if we look at why these kids are obese or why all of us are obese, we predominantly have an orexigenic arm which controls hunger, which increases hunger, and an anorexigenic arm which increases satiety working in the hypothalamus. So the predominant neurons of the orexigenic arm are gout-related peptides and the predominant neuropeptides and the neuropeptide Y. And for the anorexigenic arm, it's POMC and CART neurons. I have a very stupid acronym to remember this. A gout-related peptide AG is like arogale, and anorexigenic arm is POMC CART. So parpona ore arche. So like that. So when leptin from the adipocytes go on to act on some of these receptors, of the leptin receptors in the hypothalamus, and gives a positive stimulus to the anorexigenic arm, that is POMC CART neurons, and via other downstream mediators, alpha MSH, its receptor, the melanocortin receptors and other receptors, it reduces food intake by increasing satiety, and the opposite happens when the agouti-related peptide, these neurons are stimulated. So we are basically having problems in any of these signals or any of these receptors or the signaling molecules which causes the monogenic obesity, or it could be problem in leptin signaling itself. So talking briefly, very briefly about the monogenic obesity syndromes, because these are very rare. So leptin receptor, POMC, the enzymes that cleave POMC, and the downstream mediators like BDNF, DRKB, etc. So leptin deficiency and leptin receptor deficiency are amongst these more common. So these usually have normal birth weight, but within the first few months of life, they have a very rapid weight gain, almost insatiable hunger right from infancy, because this is because of absent leptin or resistance to leptin, which stimulates the starvation response. These in turn causes central hypothyroidism, hypothermia, and other body's responses to conserve energy. They have normal height till puberty, but usually there is an absent pubertal growth spurt leading to a low adult height. And if we do biochemistry, extremely low or unmeasurable levels of leptin, and we do have a treatment in the form of recombinant leptin for leptin deficient patients. Leptin receptor deficiency is similar, though less severe. The leptin levels are high, but it is not always true, so we do need a gene sequencing to diagnose, and we have a very interesting molecule self-melanotype. So there have been reports of leptin deficiency and leptin receptor deficiency from our country as well. This telescope-like hands is very much classic of leptin receptor deficiency, leptin deficiency, but with recombinant leptin therapy, there is remarkably good response. A huge amount of body weight loss is expected. So this is a recombinant analog of leptin, metroleptin, 0.03 milligram per kg, subcutaneous is the dose. About setmelanotide, again a remarkable discovery. This acts directly on the MC4R neuron. It is an agonist for the same, thus bypassing the need for alpha MSH, POMC, etc. and increasing satiety. This is again a daily subcutaneous injection ranging from 1 to 3 milligram daily dose. Now talking about POMC, while it cleaves to give alpha MSH, which is a satiety signal, it also gives cleave to give other molecules like ACTH, which is important for pigmentation and other responses as well. So whenever my 4-year-old toddler is singing, chubby cheeks, dimple chin, curly hair, very fair, this is the thing that comes to my mind, POMC deficiency, because these kids, apart from being very fat, they have red hair and very fair skin. But again, with setmelanotide, a very good response is expected in POMC deficiency cases as well. So POMC and PCSK1 deficiency, apart from being obese, they have ACTH deficiency, so they can have hypocortisolism and of course red hair and very fair skin. Coming to the pleiotropic, those are about monogenic obesity syndromes. Coming to the more common things, that is pleiotropic genetic obesity. So these are all kids admitted in our institute, NRS, Kolkata. So this is a 1.5-year-old boy. Body weight is 18 kgs, BMI 20.9. He had delayed motor milestones, hypotonia, and of course hyperphagia. So hyperphagia was common to all of them. A 4-year-old, again, had similar presentation with cryptorchidism on one side, and this is a 16-year-old girl. She already had type 2 diabetes, she had secondary amenorrhea, along with poor scholastic performance. So Prader-Willi has a very classic faces, narrow face or narrow bifrontal diameter, typical almond-shaped eyes, thin upper lip, downturned corners of the mouth. This apart, they have very characteristic other systemic manifestations as well, like in perinatal period hypotonia leading to decreased fetal movement. They could have breech presentation. In infancy, there are feeding problems. They are not obese from birth. Initially, they have feeding problems. Later on, they start having hyperphagia, and they could be having temperature instability. Early childhood, the hyperphagia sets in, along with intellectual disabilities, temper tantrums, etc. So we do have some clinical diagnostic criteria for Prader-Willi, and depending on the age, we have to count how many major and minor criteria they have fulfilling. But again, we have to rely on genetics for Prader-Willi syndrome diagnosis. If we look at the root cause, it is absence or non-functioning of a very critical region on the paternal chromosome 15. So as we know, all of us have a maternal allele as well as a paternal allele for every gene. And in Prader-Willi, this particular segment is not working. So this could be either due to deletion of the paternal allele itself, which accounts for 70% of the cases. It could be due to maternal uniparental disomy, that is both the copies are coming from the mother, which accounts for around 1/4 of the cases, and very rarely it could be due to problems in the imprinting center itself, causing some problems with imprinting, maternal imprinting. So if we are doing karyotyping or FISH, the only thing we can diagnose is the deletion, that too if it is a large one involving that segment like this. But we would be missing around 1/4 of the cases of Prader-Willi if we are doing only karyotyping or FISH. So for that, we need to do something known as methylation sensitive MLPA. So this detects the amount of methylation in the child, and so since both the copies are coming from the mother, we expect 100% methylation for Prader-Willi, even if it is paternal deletion or if it is uniparental disomy due to both copies coming from the mother. In contrast, a normal individual would be having 50% methylation. So if we are doing MS-MLPA, we can detect both deletion as well as uniparental disomy. So this is the result of the second child who indeed have maternal allele 100% methylation, suggesting Prader-Willi syndrome. So if we look at the algorithmic approach towards genetic testing for Prader-Willi, the first test should be methylation sensitive MLPA, not karyotyping, not FISH. Now if we detect abnormal methylation, the next step should be FISH or a microarray to detect if it is deletion, or if that is normal, then it could indicate a maternal uniparental disomy, and then rarer tests like DNA polymorphism test to understand if it is the imprinting center defect. So coming to the history and clinical examination, so apart from anthropometry, the history of hyperphagia, the developmental milestones, we do have some validated questionnaires to assess hyperphagia. Only the mother's history is not enough. We need to put these questions to understand if it is significant enough. In management, infancy, the focus should be on ensuring nutrition because they have feeding problem in infancy, and growth monitoring, adrenal cortex functioning. In childhood, in contrast, we should take steps to control the hyperphagia, growth hormone therapy, pubertal induction at time, and reassessment of adrenal function. In adulthood, more of occupational therapy and lifestyle changes. So growth hormone in Prader-Willi not only normalizes height, but also increases the lean body mass, their activity levels, and reduces fat levels, and possibly could benefit their motor development as well. It should be started early before the onset of obesity, and there is no need of any IGF-1 or growth hormone testing for that. The dose is usually lesser than what we give to growth hormone deficient children, and this is because of multiple concerns about sudden deaths that have been reported for Prader-Willi syndrome on growth hormone. The exact etiology we do not know. Whether growth hormone is responsible, that also we do not know. Sleep apnea, hypocortisolemia, these have been proposed. So we need to exert some caution before we start growth hormone in Prader-Willi. We do an OGTT, we do a polysomnography, we look for scoliosis, hypocortisolism, etc. and manage these first before we go to give growth hormone. For hypogonadism, cryptorchidism is common, so early treatment within the first 6 months. HCG, if not working, then maybe orchidopexy. Puberty, they can enter puberty, but usually there is pubertal arrest, and they do need HCG or testosterone for males, and estrogen and progesterone as for any other hypogonad cases for females. For obesity, there is a lot of data now coming about GLP-1 RAs in syndromic obesity, especially Prader-Willi syndrome, which showed BMI, HbA1c as well as improvement in satiety levels, also with oral semaglutide, and multiple other agents that have been tried. So for these 3 kids, the first kid, we started him on HCG for cryptorchidism. The child with Prader-Willi, we have planned him for growth hormone, he is undergoing sleep study now, and the lady, she is already on having type 2 diabetes, she has received growth hormone, and we are planning GLP-1 RA for her. Coming to different presentations of Bardet-Biedl, an adult obese diabetes visually challenged. Both of these are spot diagnosis. There is no need to discuss also, and this is the classic retina presentation as we know. So Bardet-Biedl can be due to affection of multiple genes involved in cilia, and this defective cilia, why it causes obesity is because it has a role in hypothalamic nuclei maturation and migration of the POMC neurons. This apart, there is also leptin resistance, all of which is caused to Bardet-Biedl. Again, we have clinical diagnostic criteria, and apart from night blindness, it's important to identify they can have hypertension, they can have renal anomalies and needs periodic ultrasound and renal function monitoring, and these can be identified and prenatal ultrasound as well, polydactyly as well as renal anomalies. Thus, there is a room for genetic counseling. So again, management, apart from hypogonadism, we know apart from providing them gonadal therapy, they can have some other anatomical problems also because of their syndromic and they are mostly infertile. So yearly monitoring. Obesity management, again environmental modification most important, but high protein diet should be avoided because they have a risk for hypertension and renal problems. And anti-obesity pharmacotherapy, we have data with setmelanotide. It is FDA approved now for Bardet-Biedl syndrome in patients above 6 years of age. GLP-1 RAs have not been extensively studied in Bardet-Biedl, but may not be as effective. They have shown poor response to bariatric surgery. This will be all know pseudohypopara, they can have hypocalcemia, seizures, Albright's hereditary osteodystrophy, and this short fourth metacarpal. Typical phases of Carpenter's syndrome, Cohen's syndrome, we need to identify. And the most recent one, the Rohat syndrome, in which they have very sudden onset of hypothalamic dysfunction and a very high incidence of cardiorespiratory arrest. So this is another new entity. They have high risk of sudden death because of respiratory manifestations, autonomic dysregulation and hypothalamic dysfunction, which we need to monitor. So I tried to find out what happened to Lokman, and unfortunately I found that he actually died while choking while being fed on a Sunday. So in news media the reported is that it has Prader-Willi syndrome, but I beg to differ. 8-month-old, such obesity, choking, I think it could be something else, maybe some monogenic obesity which were missed at that time. So we do have some light at the end of this tunnel, at least for Prader-Willi. We have growth hormone, we have GLP-1 RAs and timely treatment of hypogonadism. We also have recombinant leptin for the monogenic obesity and setmelanotide for many of these diseases. So monogenic and pleiotropic syndromes are multiple which could cause genetic obesity in children. For Prader-Willi, MSMLPA and not karyotyping is the first line genetic test. Bardet-Biedl is mostly a clinical diagnosis. We could do next generation sequencing for confirmation. Growth hormone, hypergonadism and hyperphagia correction are the cornerstones of therapy in Prader-Willi. Of course, supportive care is still what we can offer to patients with Bardet-Biedl syndrome. Setmelanotide is effective but not available in India and very costly. And there is a promising role of GLP-1 RAs in all these diseases. So all of us are familiar with this meme that obesity does not run in families. It does that the families do not run, but we now know that it's not true. Obesity does run in families, but thankfully, although it is in their genes, it is in their destiny, we can do something for them, unlike some more bigger disasters for which we cannot really do something. Thank you so much.